Good afternoon, everyone. I'm here going to present a new stereopsis test being designed at our center. I have no financial interest. So I'm going to present a new stereopsis test which is bichromatic in nature and gradable. That is, we are going to trying to measure the minimum and major disparity appreciated by any subject. The test was designed using a pair of red-green contour bars on a neutral gray random dot background as shown in this figure. We simulated the conventional CP6 NIDEC projector chart to the start slide of our stereopsis test as being shown in this figure. The test was designed to run as a presentation of a total of 35 slides in which the horizontal disparity between the two contour bars was gradually increased as shown in these figures. To rule out false positive, plates with red-blue bar were inserted randomly in the presentation. So this was the first start slide generated through the CP6 NIDEC projector chart in which the neutral gray random background was chosen to reduce the glare and geometric figures were used to enhance the effect. We chose a total of 15 subjects, 7 normal and 8 intermittent XT patients. The inclusion criteria were the age was above 5 years, emetropic patients with corrected refractive error, intermittent exotropia patients, patients having fusion, non-operated, non-traumatic and non-syndromic patients. The test was conducted in a dark room at a distance of 3 feet with red-green goggles. Subject was asked to appreciate stereopsis on the first slide. Then the presentation was run manually in which the horizontal disparity between the bichromatic bar was gradually increased. Subject was asked to report when the popping of bar starts, that is the stereopsis minimum, that is when the minimum disparity appreciated by the subject, and when it subsides, that is stereopsis maximum, that is the major disparity appreciated by the subject, the point at which fusion was still maintained and stereopsis lost, as the patient doesn't have any diplopia or any suppression at that point. Knowing the 10 arcsecond of stereo acuity and distance between two bars on CP690 projector chart, it was extrapolated to our chart. So the stereo acuity value was calculated per click on our chart, which came out to be 1 arcsecond per mm of the click. So we have 7 normal subjects of 26.9 years of age and 8 intermittent XT patients of 13.5 years of age. The age was not comparable in our study. So in this chart, it is showing that the disparity major value is being reduced in intermittent XT patient as compared to the normal patient. So coming to the discussion, stereopsis results due to the binocular horizontal disparity in Panam's fusional area. Binocular neurons use interocular phase differences, phase disparities, and interocular position differences to encode disparity. Images with cross disparity are perceived in front of the screen, and images with uncrossed disparity are perceived behind. The merits of this test are that it is free of cost. We have used bichromatic vertical bars. It has been theorized that stria cortex possesses a specialized mechanism for processing vertical contours, and it can be done with simple red-green goggles. The limitation of the test design, that the convergence was a major confounding factor in our test. It has been theorized that disparity selective neurons also play a major role in generation of the convergence eye movements, showing relatively high disparity values and giving falsely high stereopsis values. We have used red-green anaglyph in our chart, and color is supposed to be an important feature of 3D imaging. It has been shown that certain cortical areas are tuned for both color and binocular disparity, and the stereoscopic depth perception varies with the chromaticity. And one more major limitation of our test was that we use a linear horizontal distance between the two bars on the CP6 NIDEC projector chart to tell us the stereopsis value, whereas it projects a delta Z as shown in this formula and shown in this figure by the arrow. It was difficult for young children. It has a high associated learning curve, need longer span of attention. The limitation of the study was that the sample size was very small. It needs further bigger studies and research for implication of test in routine practice. Convergence need to be negated while performing the test for true and more reliable results. The test was validated with CP690, but it doesn't show any clinically significant. So here I conclude. The stereopsis could be graded and minimum and maximum disparity values could be graded. So here I am trying to project a primary level work of stereopsis done at our center which needs further higher studies and research. Thank you.